Hey everyone, I'm James. I'll be doing the neonatology lecture for this year. Um, Neonatology is obviously quite a big topic. So this talk will mainly be covering the R1 conditions, but it will cover some R2s and R3s that I think are relevant to your exams. Just to note that the slides aren't in too much detail. So if you do want a bit more info about some of these topics, then feel free to head over to our summary sheets, which are on the MUPPITS Google Drive. And they'll have quite a bit more in-depth information about some of the topics. And they'll also you can also find some of the other conditions that aren't talked about here as well. So in terms of the overview, we'll start off with some definitions, and then we'll cover most of the common presentations in neonates. So in terms of the definitions to know, obviously the age groups. So a neonate is defined as a baby in their first 28 days of life. After that, so from 1 month to 12 months, they'd be classified as an infant, and then from 1 to 3 years, they'd be classified as a toddler. The gestational ages, so a term baby is obviously 37 weeks or above. A post-term baby is a baby born at more than 42 weeks of gestational age. Whereas on the other side, a moderate to late preterm baby is around 32 to 37 weeks, whereas a very preterm baby is between 28 to 32, and an extremely preterm is less than 28. And that's when you start to think about having those discussions about viability. I think the other thing to know would be chronological age versus corrected age. So chronological age just refers to the age of the infant from birth. So however many weeks they are from birth is how old they are. Whereas corrected age accounts for the preterm gestation. So that's very useful for babies that are born a bit premature. So for example, a 12-week-old baby would be classified as 12 weeks old chronologically. But if they were born 8 weeks premature, then their corrected age would be 4 weeks. And the reason that that's important is that you would expect them to be hitting the milestones of a 4-week-old baby rather than a 12-week-old baby. And that's generally useful until about 2 years of age. Although if you ask different people, they'll give you different answers on how long it's useful for. A couple more definitions. So when talking about birth weight slash size, SGA is less than the 10th percentile, whereas LGA is greater than the 90th percentile of weight. Macrosomia is usually above 4 kilograms of weight. They're normally born to women with diabetes. A normal body weight for most infants is between 25 and 3,500 grams, although there is a bit of variation there. And then low body weight, very low body weight. And then finally, extremely low body weight is less than a kilo. Just a note that it is completely normal and actually expected for babies to lose some of their body weight when they're first born. So within the first 5 days of birth, a loss of around 7 to 10% of body weight is completely normal. But that is only normal if it's regained within the first 2 weeks. So any loss of body weight that's greater than 10% or any loss of body weight that's not regained within the first 2 weeks is abnormal. And you'd have to consider sort of issues with feeding or issues with metabolism. The average weight gain per week, so between 0 and 3 months, it's about 150 to 200 grams per week, which is quite significant. And then that slowly sort of tapers off as the baby grows older. Cool. So talking about prematurity now. So this is defined as a baby being born before 37 weeks of gestation. But again, that does come on a bit of a spectrum. I think it is quite important to know some of the risk factors. So the maternal risk factors being at the extremes of age, so very young or very old, puts you at a greater risk of prematurity. Like anything, a previous and a past history is quite important. Cervical insufficiency, preeclampsia can cause it as well. And then again, like anything else, smoking and alcohol are very big risk factors. From the fetal aspect, really thinking of anything that would cause stretch of the uterine cavity or cause the cervix to open up a bit earlier. So macrosomia, multiple pregnancies, polyhydramnios, they sort of all have the same pathophys in terms of causing prematurity. And then any uterine abnormalities, multiparity, and fetal compromise as well. And then when considering the placenta, which is the other aspect of this, APH, PPROM, and choreo would be your main risk factors for prematurity. In terms of some of the complications, obviously there's a lot more than this, but I decided to focus on the main sort of systems. So from cardiorespiratory aspect, RDS is a big one, which we'll talk about in a little bit, but from a cardio aspect, patent ductus arteriosus is something that does occur. Neuro, your main thing would be an intraventricular hemorrhage, although a retinopathy of prematurity is also quite significant. And then from a gastro and renal aspect, necrotizing enterocolitis would be your main complication. Systemically, hypothermia. So a lot of these babies will be born hypothermic. So trying to warm them up, keeping them in a nice warm environment until they regain their body temperature is very important. And then other things, jaundice. Yeah, so prematurity puts you at risk for a bunch of different conditions that can cause jaundice. So that does make sense. And then things like hyperglycemia, electrolyte imbalances are pretty significant as well. At the bottom is the zone of parental discretion. So this is, I think, a Victorian or Australian version. So this does vary between different countries. But essentially, if a baby is born at 24 plus 0 weeks or more or older, then active management is always recommended. Whereas if you move a bit younger than that, then it does start to get a bit complicated. So between 23 plus 0 and 23 plus 6 weeks, then active management will be recommended, but parental views will be respected. So if the parents don't want to continue with the pregnancy due to some of the risks, then that will be respected. Whereas vice versa, if it's between 22 plus 0 to 22 plus 6 weeks, then active management won't be recommended. So they'll recommend PAL care. But if the parents want to continue with the pregnancy, then that will be respected. And then anything younger than that, so less than 22 plus 0 weeks, active management won't be recommended at all, just because of the severe risk of complications from that. Of course, that was prematurity. Moving on to sepsis now, which is quite a big topic. First of all, classification, it can be classified as either early onset or late onset. So early onset is 48 hours or less, whereas late onset sepsis is past those 2 days. And it is important to classify it based on that because it will affect the causative organisms or the most likely causative organisms, and that will in turn affect your management options as well. In terms of how it presents, it can present quite non-specifically like it can in adults. So your systemic symptoms of pallor, lethargy, jaundice, and then hypothermia or hyperthermia, so really any extreme in temperature would cause some alarm. Hemodynamic instability, again, like in adults, tachycardia, hypotension, respiratory distress as well. From a GIT aspect, poor feeding can be a sign of an infection. And then if on top of that, if you're suspecting a gastro origin, then abdominal distension and vomiting as well. If you're suspecting something from a CNS origin, like a meningitis or an encephalitis, and seizures can be present on top of that. In terms of the causative organisms, so for early onset, your most likely causes are going to be GBS and E. coli. And that makes sense because it's normally vertical transmission. So it's going from the mum to the fetus. So anything that sort of colonizes that area can be passed on to the baby. And the other two main things to consider would be listeria and enterococcus, in particular for preterm babies. Comparing that to late onset, your most common causes are going to be staph. So coagulant staph or Staph aureus are probably the two most likely causes of late onset sepsis, but other things are Pseudomonas, Klebsiella, Latin Candida, which should be ruled out. In terms of the risk factors for each of the types, so for early onset, as I mentioned, that's normally vertical transmission. So anything that would increase the likelihood of mum passing on bacteria to the baby. So prolonged rupture of membrane greater than 18 hours is a very strong risk factor for early onset sepsis. A maternal fever greater than 38 degrees is quite self-explanatory. And then either a past history or a current history of GBS, bacteriuria, puts you at a much higher risk of GBS causing sepsis. Comparing that to late onset, which is usually horizontal transmission, so a prolonged NICU admission, obviously there's a lot of bugs going around NICU. So any prolonged admission puts you at a much higher risk of late onset sepsis. Like in adults, any foreign bodies, so IV catheters, ETTs, and then any anatomical malformations, so in particular urinary tract abnormalities that put the baby at risk of UTIs. So for the workup of neonatal sepsis, obviously doing your septic screen, so bedside, that should say urine MCNS, but that's very important. Bloods, trying to take 2 blood cultures, and we'll talk about that in a little bit. But that is your most important, the most important part of your management or investigation, sorry. And then doing just your basic bloods, your FBE and CRP. Doing a VBG will likely show elevated lactate, particularly if they're in septic shock, and then doing electrolytes as well, given that they're probably not going to be feeding as well as they would. Any other investigations are sort of dependent on the clinical picture. So doing a chest X-ray if you suspect a respiratory cause, and doing an LP if you suspect something like meningitis. In terms of the prophylaxis, the main thing would be for mums that are GBS positive on screening tests. So they'll be given 3 grams of IV benpen as a loading dose intrapartum, and then for every 4 hours that labour carries on, there'll be a 1.8 gram infusion of benpen. In terms of the management for sepsis, obviously it's a medical emergency, so doing your doctor's ABCD and escalating to the appropriate people, and I'd recommend early NICU involvement as well, just because these babies can get quite unwell very fast. Volume expansion, so giving a fluid bolus is very important, and as I said before, blood cultures, at least 2 blood cultures should be taken, but in neonates, which sort of differs a bit from some adults, is that antibiotics shouldn't be delayed to get blood cultures. So in adults, you often will take the blood cultures before starting antibiotics, whereas in neonates, just because they can get sick so fast, it's very important to not delay antibiotics. And your empirical therapy for early onset sepsis will be benpen and gent, whereas for late onset sepsis will be fluclox and gent. And that's because your most likely cause of early onset sepsis is going to be strep, which is best covered by benpen, whereas your late onset is going to be staph, which is best covered by fluclox. And then in particular circumstances, you can consider adding other antibiotics. So if you're suspecting NEC, then either adding amoxicillin or MET on top of the 2 things already mentioned. If you're suspecting meningitis, then cefotaxime would be the agent to add. And if you know that the baby's HSV positive, then adding acyclovir would be indicated. And then on top of all your antibiotics and everything, your supportive care, so oxygen support, fluid resus, and cardiovascular support. And as I mentioned before, most of these babies will require NICU admission, if not all of them. So ensuring that NICU is involved quite early on. Cool. Moving on to RDS. So this used to be called hyaline membrane disease. I put the pathophys there because I think it is quite important and you can get examined on it. And so this classically occurs in premature babies, just because the lungs aren't mature yet. So the pathophys is essentially a lack of surfactant leading to alveoli collapse. And as a result, you get a decrease in end inspiratory pressure. And the physiological response to a decrease in end inspiratory pressure is to grunt. And that essentially is an attempt to try and keep the alveoli open by increasing the end inspiratory pressure. So grunting is quite characteristic of RDS in neonates. Just to note that this is less common than TTN, so transient tachypnea of the newborn, but it does tend to have a greater morbidity. It will normally worsen over the first couple of days, and then it should resolve within about a week. The clinical features are quite non-specific, so tachypnea, tachycardia, and cyanosis are very non-specific features. But the main thing that would alert you to it is grunting. And on top of that, obviously doing a chest X-ray as well. The management for this, so to prevent this, if you know that the baby is going to be born at less than 34 weeks, then giving antenatal betamethasone if there's time. So that's indicated at less than 34 weeks. There's not a whole lot of evidence to say it's useful beyond that, so it doesn't tend to be given after 34 weeks. And that just helps to mature the lungs. CPAP and PEEP to maintain your airway pressure and trying to keep those alveoli open until it passes over. And then if it is persistent and there is quite significant respiratory distress, then considering intubation and giving surfactant as well. So comparing that to TTN now, this is the more common cause or the most common cause of respiratory distress in a newborn child. Although, as I said, it does tend to be a bit more mild than RDS. The pathophys behind this is essentially insufficient clearance of alveolar fluid, which in turn leads to pulmonary edema. And this will classically occur following C-sections, so when there's that quick transition into the outside world. And this normally occurs within the first couple of hours of birth. It should resolve a lot faster than RDS, so usually resolves within the first 2 to 3 days of life. And the clinical features can be quite similar. So tachypnea, cyanosis, and increased work of breathing. Those symptoms are shared with RDS, although you're more likely to see crepitations in TTN just because there's that fluid in the lungs. The mainstay of management is essentially supportive, so giving supplemental O2 and giving feed support if required. And just a note to not give diuretics in TTN. There's no evidence that it does have any improvement in TTN. So you're essentially, there's really no reason to give it. So these are the chest X-ray findings. These are the best 2 images that I could find, although they do look a bit similar to each other. So in TTN, it's very non-specific chest X-ray findings, so hyperexpanded lungs, alveolar edema, and just fluid essentially. And you probably wouldn't be able to see prominent vasculature in this X-ray. Whereas RDS, you have lower lung volumes, so that does differ, and then a ground glass appearance with air bronchograms. And I've tried to put an arrow to the air bronchograms if you can see them there, but that would be more indicative of RDS. And normally this is pretty much symmetrical, so both sides of the lung should be quite similar. Moving on to neonatal jaundice. So in terms of the approach to jaundice, I think there's a couple of questions to ask. So the first thing is it pathological or physiological? And that tends to be decided by the timing of the jaundice. So if it's first noticed within 24 to 48 hours, this is always pathological. So there's never physiological jaundice that presents within the first 2 days of life. And your most common causes are going to be sepsis and hemolysis. So those are the things you have to rule out immediately. After that, so between 2 days and 2 weeks, this can be pathological, but it's most likely to be physiological. So you still have to rule out hemolysis and sepsis, but physiological jaundice would be your most likely differential. And then your other things to consider would be breastfeeding and breast milk jaundice. Anything past that, so from 2 weeks on, is likely pathological. There's a very small chance it could be physiological still, but it is most likely pathological. And this is when you'd have to start to consider your structural causes. So the main thing would probably be biliary atresia. So once you've decided whether it's pathological or physiological, the next question is whether it's conjugated or unconjugated. And to decide that, obviously, you have to do serum blood tests. So your main causes of conjugated bilirubinemia would be biliary atresia, choledochal cyst, neonatal hepatitis, and then your metabolic disorders. Whereas if it shows to be an unconjugated bilirubinemia, then pretty much considering the causes that we talked about. So the ones to rule out would mainly be sepsis and hemolysis first. Cool. So hopefully that made sense. In terms of the workup for these babies, the history, the main questions to ask would be the age of onset, so the timing essentially, which we've already talked about, but then taking a good antenatal history. So trying to understand the maternal blood group and antibodies and asking for any antenatal infections as well. From a birth aspect, any trauma or instrumental delivery during the birth is important to ask for, just because there could be some scalp bleeds. And then asking about feeding as well. So are they breastfed or are they formula fed? And how has their weight gain been? Output can be important to ask about as well. Dark urine and pale stools is normally an indication of biliary obstruction, so that can hint towards atresia, and then getting a good history about their hydration status as well. And then, like any history, a family history and a past history is very important. The main investigation, so the first thing to do would be a serum bilirubin, so that can help you to decide whether it's a conjugated or unconjugated bilirubinemia. LFTs are routinely done, and then your septic screen as well. A hemolytic screen is very important, and the main things of that would be LDH, haptoglobin, a Coombs test, and a blood film, as well as your blood group and antibodies from both the mum and the infant, would probably be the most important thing to do there. And then you can consider doing a hemoglobin electrophoresis for thalassemia as well. Your other investigations are mainly not usually done in the acute setting. So this would be if it persists beyond a couple of weeks, because it's mainly looking at structural causes. So things like a biliary ultrasound or a liver biopsy. The management of neonatal jaundice. So firstly, it's not included on the slides, but the mainstay of management is firstly to try and reverse the cause. So if it's sepsis, trying to reverse that before doing anything else. But in terms of managing the actual jaundice itself, the goal of management is essentially to prevent bilirubin encephalopathy, which is a nasty brain injury that you can get when the bilirubin levels are really high in the blood. So the goal behind this is just to try to reduce the amount of bilirubin in the body. So you'll get a chart similar to this. There's a lot of different charts, but they all have the same principles. And essentially the idea is to plot the unconjugated bilirubin on the chart. So do your blood tests and find that out. If risk factors are present for severe disease, then use the lower line. So it's the dotted line here. The dotted line in the red and the blue would be the lines that you'd use. For most babies, it would be the other line. So if you plot it and your spot is below both curves, so it's below the phototherapy curve, then there's no active management required and you just have to watch and wait. If it's above the phototherapy curve, but below the exchange transfusion curve, so somewhere in between here, then you would begin phototherapy. Whereas if you're above both curves, so all the way up here, then you would commence exchange transfusion. Cool. And I doubt you would be asked to do this without being given a graph to plot it on. So in terms of what phototherapy is, this isn't very important, but I thought I'd chuck it in for completion's sake. Essentially what happens is blue light is given, and that causes breakdown of bilirubin and then excretion via the urine. And the important thing to do would be to monitor serum bilirubin every 6 hours to see progression. Your complications, again, aren't too important, but your main things to consider would be retinal damage and an ileus, in particular in preterm infants. Exchange transfusion, so this is for the really unwell babies. Essentially, you remove the blood from the fetus and you replace it with donor blood. So it is quite simple. Most of the complications are related to the procedure itself, so catheter related, but you can also get necrotizing enterocolitis and sepsis would be the main two things to consider. Cool. Moving on to hemolytic disease of the newborn. The definition of this is essentially destruction of neonatal red blood cells by maternal IgG antibodies. And your main two subtypes are rhesus incompatibility and ABO incompatibility. So I think this is important to know. Rhesus incompatibility occurs in a rhesus negative mother with a rhesus positive fetus. So that always happens. It pretty much always affects your second pregnancy because sensitization has to occur first, and that normally occurs in the first pregnancy. And then by then the mum will have built up the antibodies and they'll go on to attack the second fetus. This is less common than ABO, but it does tend to be a bit more severe. So comparing that to ABO incompatibility, the mother's blood type will be O and the fetal blood type will be either A or B. The difference here is that this can affect the first pregnancy. It can also affect the second pregnancy, but unlike rhesus, this could affect the first pregnancy as well. And as I mentioned, it's more common, but it's normally less severe. But there are obviously exceptions to that. This is a quick diagram. I won't go through it now, but if you wanted to have a look at in your own time, I think this does help to sort of understand the pathophys behind rhesus incompatibility. So having a look at this, I think would be a bit useful. In terms of the presentation and investigations for this, it is pretty much identical between the two different subtypes. So the presentation would be early onset of jaundice, so normally within the first 24 to 48 hours following birth, but it can present after that with an unconjugated bilirubinemia on the bloods, and you can get symptomatic anemia as well. Your investigations, obviously, your main one is going to be your maternal and fetal blood group and antibodies. That can help you to rule out hemolytic disease if the blood types are compatible. Other things to do would be serum bilirubin, including unconjugated and conjugated bilirubin, a direct antiglobulin test, so a DAT. The thing to note here is that a positive result would confirm HDN, but a negative result doesn't necessarily exclude it. So doing a DAT can't help you to exclude HDN, whereas, or for certain at least. And then your other basic things would be an FBE and a blood smear with a reticulocyte count as well, which will indicate hemolysis. So the diagnosis of this essentially requires meeting of all three of these criteria. So you have to have incompatible blood types between a neonate and a mother. If they're compatible, then it can't be hemolytic disease, and you have to consider other diagnoses. You have to have some lab evidence of hemolysis. So that can be either unconjugated bilirubin, anemia with high reticulocytes, or it can be a peripheral blood smear that's consistent with hemolysis. So any of those three things would be enough to satisfy that point. And then lastly, you need a positive DAT. So you can't diagnose hemolytic disease of a newborn without a positive DAT in most cases. Lastly, in terms of the management, so prevention antenatally, pretty much every person will get screening for maternal antibodies unless they refuse. And then in severe cases, you can do fetal red blood cell transfusion. That can be done in utero, but that's generally reserved for quite severe cases. Postnatally, as we talked about before, doing your measures to correct jaundice, so that'll most likely be phototherapy, but it could be exchange transfusion. Giving IV IG is generally indicated, and if you're suspecting hydrops vitalis, which is obviously an emergency, then you have to go through with emergency transfusion. Well, moving on to neonatal resus now. So I'm sure you've seen this this document before, or this chart. I think it is worth knowing this chart pretty well. I do delve into some of this stuff. But I think just trying to know this chart would be very helpful. So talking about APGAR scores first, so these are scores that are done at 1 minute and 5 minutes post-birth for all babies that are born in a hospital, and they can be done at 10 minutes if there's concern about the baby's well-being. Just to note that most babies won't score 10, they'll score a 9, just because most babies are born with blue peripheries. So it's completely normal and normally expected for the baby to score 9. But any score 7 or above is considered normal. Any score between 4 and 6 is low. And any score of 3 or less is critically low, and they need pretty urgent intervention. This is a scoring chart on the right. I think it is probably worth knowing or having at least a rough idea of this. I doubt they would ask you to work out an APGAR score without giving you a chart, but it is possible, I guess. So knowing some of this stuff could be a bit helpful. The first thing to do in a neonatal resus setting is to warm and stimulate the baby. So don't delay cord clamping if you think the baby's unwell. So don't wait 1 or 2 minutes or whatever the guidelines are, but cut the cords straight away and move them to the resuscitator. And the idea of that is to try and maintain temperature. So it's essentially just a warm cot. I chucked a labeled picture of it on the right. If you haven't done your ONG rotation yet, I think it would be worth having a look at it, or asking the bird suite nurses to run you through it, because it is quite a cool machine. But essentially, yeah, the main part of this is just trying to move them to the resuscitator, maintain their temperature, and to dry and rub with the warm towel. Drying and rubbing with a towel is often enough to give the baby a kickstart. But if it's not, then obviously moving on to your next steps. Yeah, so like in adults, the next thing to do is to look at the airway. So having a look, listen, and feel for any airway obstruction. In terms of the ideal head position, it's normally neutral. So putting a shoulder roll, like a roll-up towel or whatever, beneath the shoulders can help to maintain that position and keep the airway open. And then your simple airway maneuvers, again, are the same for adults. So a head tilt chin lift or your jaw thrust. And then suction is normally recommended. If there's obvious meconium, it's not recommended for any other cases. Breathing. So again, looking for your chest rise and fall, making sure that the baby is breathing, auscultating the chest, looking for any crepitations or signs of infection, etc. Generally, intervention here is indicated if the baby's either gasping, if they're apneic, or if the heart rate is less than 100. And the main intervention would be PPV with a consistent SpO2 monitoring. And then further on, you can consider intubation or LGA. Cool. CPR is further down. So the main reason that breathing takes the priority over CPR is because in neonates, it's more likely to be a respiratory cause of the arrest, whereas in adults, CPR is more important because it's more likely to be a cardiovascular cause. But nevertheless, if pulses are absent or if the pulse rate is less than 60, then CPR is indicated. Make sure you're always assessing your central pulses. It's very hard to feel pulses, peripheral pulses on babies anyway. But if they're on top of that peripherally shut down, then it's almost impossible. So go for your brachial, femoral, or carotid pulses to assess the pulse. The compressions is done at 15 to 2 as opposed to 30 to 2 in adults. And again, the main reason behind that is that it's more likely to be a respiratory cause. The technique for CPR, the main two techniques are shown on the right. So I think the most commonly used one is the two hands around the baby and using the thumbs, but 2 fingers would work as well, just in the center of the chest. The rate is 100 to 120 beats per minute, ideally, and then also assessing for any shockable rhythms as well. Circulation. So if the heart rate remains less than 60, sorry, despite your compressions, you'd move on to IV adrenaline, and that can be given every 3 to 5 minutes. It's given in your 1 to 10,000 solution for IV, and then your dosing, I doubt you would need to know, but just for reference, it's there. And the main other thing to consider would be volume expansion. So either through packed red blood cells or just normal saline. Cool. So moving on to an R2, torch infections. This is an R2, but I think it is quite important and it can be very examinable. So your T is for toxoplasmosis. So that is classically transmitted via cat feces. So that is a bit of a buzzword, and it's a parasitic infection. Maternal presentation is often asymptomatic, so they normally won't know that they have it. But neonatal complications, your main 2 things would be hydrocephaly and intracranial calcifications. The blueberry muffin rash, there's a picture of it on the right. It does occur in toxoplasmosis, but it's not specific. So it can occur in a few of these infections. And then your buzzword is going to be granulomas on the placenta. That's a bit of a buzzword. In terms of the prophylaxis for it, just doing adequate hand hygiene, trying to avoid undercooked meat, and obviously avoiding emptying the cat litter if possible. The management, I would doubt that you need to know it, but if you did want to know it, it's pyrimethamine, sulfadiazine, and folic acid. Moving on to rubella. So rubella can be quite nasty if it's transmitted early on, although the transmission to the fetus is very dependent on the gestational age. So if it's less than 12 weeks of GA, then, or if infection occurs at less than 12 weeks GA, then pretty much all of these babies will have rubella. So that's around 90 to 100% transmission. Whereas if it's more than 24 weeks of gestational age, then there's a less than 1% chance of transmission. So that is very important. In terms of the maternal symptoms, it's very non-specific. So it's salt and pepper rash, cervical lymphadenopathy, and joint pain. So yeah, very, very non-specific presentation, but it is something that's important to screen for. The neonatal complications, The main thing would be congenital cataracts, which would go on to cause blindness, and your cardio complications would mainly be pulmonary stenosis and paired ductus arteriosus. The main management, firstly with prophylaxis, is the MMR vaccine. So hopefully pregnancies, before pregnancies, women are having the MMR vaccine. But in terms of the management, if the infection is had uh, before 16 weeks, then termination is normally recommended. Whereas if it's more than 16 weeks, then reassurance is normally all that needs to be done. So reassurance that this is unlikely to be transmitted to the baby. But there's not a whole lot of active management that can be done other than that. Moving on to CMV. CMV is the most common of all these congenital infections. It's normally transmitted via bodily fluids, and your maternal symptoms, again, are very non-specific. It'll present similar to EBV or glandular fever. So fever, lymphadenopathy, maybe a rash. The neonatal complications, your main buzzwords here will be microcephaly and periventricular calcifications. So going back and comparing it to toxoplasmosis, toxoplasmosis has hydrocephaly, so a big brain, big head, and intracranial calcifications. CMV has microcephaly, so a small head with periventricular calcifications. And I think a good way to remember it is the V in ventricular is for CMV. So that can help you to remember which one CMV is. And then your other things would be thrombocytopenia, jaundice, and chorea. The management, I don't think is too important, but essentially just high dose IV antivirals. Herpes, the most common strain would be HSV2 that's passed on to infants. Your maternal symptoms are going to be most likely asymptomatic, but they can have some vesicular lesions. And your main neonatal complication to be wary of is herpes encephalitis, which can be a nasty complication of this. And again, the management is the same thing, high dose IV antivirals. Moving on to the other infections, there's a whole bunch of them. I've listed the main three as syphilis, parva, and HIV, but there are a bunch of other ones. The neonatal complications of syphilis can be very, very severe. So stillbirth and hydrops fetalis would be obviously the two very severe ones. Hutchinson's teeth is quite specific to neonatal sepsis, syphilis. So maybe searching a picture of that could be beneficial. And then just your other things, your maculopapular rash, sensory neural deafness. And the main management for this is just penicillin. Parvovirus is a very big cause of anemia in the newborn, and your main neonatal complications would be aplastic anemia. So that's, again, a bit buzzwordy, and hydrops fetalis. HIV is not so common anymore, just due to all the screening stuff, but the main neonatal complications would be recurrent infections and chronic diarrhea, although nowadays HIV is very rarely passed on to the neonates. The main aspect of management is just advice to the mum regarding breastfeeding, etc. Cool. The last thing to talk about is birth trauma. So I think having a look at this slide and trying to understand where each of the bleeds occur could be quite helpful, just because it will give you some info about which ones are more serious and which ones aren't. So the main three to differentiate between are caput, cephalohematoma, and subgaleal hemorrhage. And they're listed essentially in order of severity here. So caput is your least severe one. It's mainly associated with head moaning when you get external pressure from the birth canal during birth. A cephalohematoma is normally associated with a forceps delivery, whereas a subgaleal is normally associated with vacuum extraction. And the pathophys behind this is just rupture of the emissary veins. The way to differentiate them, essentially a cephalohematoma doesn't cross the sutures, whereas the other two do. So a cephalohematoma, as a result, would be quite distinct because it's not crossing those suture lines. It'll begin quite firm and then move on to being fluctuant. Your caput is going to be soft. It'll be quite vaguely demarcated, again, because it does cross the suture lines. And your subgaleal hemorrhage will be very mobile and foggy, and the babies will be normally a lot more unwell in a subgaleal hemorrhage. In terms of the progression of them, a kaput will be largest in size like right after birth, and it will normally resolve within the first day or two. A cephalohematoma will begin to increase in size over the first day, but then gradually resolve over the next 2 to 3 weeks. Whereas a subgaleal contrasts from that in that it just continues to grow in size until management, essentially. In terms of the management, kaput is essentially just always expectant management. It's not going to cause anything serious. Cephalohematoma is normally expectant management, so most cases will be expectant, and that's because the blood is confined within the periosteum, so you get limited bleeding. Whereas in subgaleal, there's no potential. There's unlimited potential for bleeding, essentially. And a subgaleal is a medical or a neonatal emergency, so escalating immediately, getting NICU involved, as well as possibly your surgeons, and doing your doctor's ABCD. And then resuscitation and transfusion would be your mainstays of treatment. Cool. So that's pretty much all I had to cover. If you've got any questions about anything covered here, feel free to shoot me an email on there or just chuck me a Facebook message. Yeah, the references are there. So most of this was from the Royal Children's Guidelines. So I think sussing the RCH guidelines can be very beneficial. They've got a whole lot of stuff and it's a lot more detail than this. Last year's MUPPITS revision lecture by Rachel was brilliant. And then other things are Radiopedia and Monash Prompt. So I would recommend checking those resources out as well. But cool. Thank you very much and good luck for your exams.